Stroke Organization President, Professor Sheila Martins from Brazil, who's going to share on the PROMOTE study, Polypill and Riskometer to prevent stroke and cognitive impairment in primary health care. Sheila, please.
Thank you, Deidre. So I'll talk about Polypill and Riskometer to prevent stroke and cognitive decline in primary health care. The PROMOTE study that was an initiative of the World Stroke Organization. So non-communicable disease represents a global epidemic and an important cause of morbidity and mortality worldwide, especially in low and middle income countries. Since approximately 9% of stroke cases and 40% of dementia cases are attributable to modified risk factors, it's necessary to implement prevention strategies to reduce the overall impact of this disease and can work together with these risk factors that combined can decrease the risk of stroke and dementia. The increased burden of stroke and dementia provides strong evidence that currently used primary prevention strategies are not enough. Only to treat the high-risk patients do not decrease the incidence of stroke. 80% of strokes and cardiovascular disease occur in people with low to moderate risk. The increased risk of cardiovascular disease, including stroke, is not restricted to those with hypertension or hypercholesterolemia, but is continuous from systolic blood pressure 115, diastolic 75, and a total cholesterol level of 135. Treating high-risk patients is already well-defined. Using population-based and low-cost strategies may reduce the risk in low and middle-risk patients. This was an initiative of Michael Brennan discussing cut stroke in half with Polypill for primary prevention and multi-level community interventions, including Riskometer and work with community health workers. So for this, we discussed with the Ministry of Health of Brazil, and the Ministry of Health is sponsoring this study. The purpose is to test whether a polypill used alone or in combination with lifestyle modification, a stroke riskometer, will reduce the incidence of stroke and cognitive decline in a population of individuals with low to moderate risk of stroke. So it's a randomized clinical trial phase 3, prospective double-blind placebo control, cluster randomization for the riskometer in the primary care units, and randomization of individual patients for polypill versus placebo. This is the pilot study in the city where I live. The polypill is composed by rosuvastatin, 10 milligrams, amlodipine, 5 milligrams, and valsartan, 8 milligrams, with the possibility to decrease the doses of amlodipine, another polypill, to patients with symptoms to try to include in the trial. So the riskometer, the patient can evaluate their own risk factors, can calculate the risk in 5 and 10 years compared with the same sex and age, can see the risk factors, and can learn how to modify them. So we are using the riskometer in this study and also calls once a month to recommend lifestyle modification to the riskometer group. So the pilot study is in south of Brazil, 80 primary care units, randomized to usual care versus riskometer, and after individual randomizations for polypill or placebo. We calculate the sample size for the pilot, feasibility study, 352 participants with a surrogated endpoint in 6 months. So we have a running phase where all patients receive the active medication, the polypill, 30 days to evaluate if they can be randomized. And the randomization is by minimization, by considering age, sex, systolic blood pressure, total cholesterol, and level of education. Were included patients with 50 to 75 years old, systolic blood pressure 120 to 139, no history of ischemic stroke, transient ischemic attack, cardiovascular disease, and LDL less than 190, and presence of one or more lifestyle risk factors: smoking, overweight, blood mass index more than 25, physical inactivity, and health diets. So the sample size for the pilot was calculated to detect 2 millimeters difference in systolic blood pressure and 3 millimeters in the LDL cholesterol. So this sample size, and because this study was for feasibility of the implementation of a clinical trial in primary care in a middle-income country. So the primary operational endpoints, number of patients recruited, tolerability of the Polypill, that is new, and the secondary recruitment rate, loss of follow-up, adherence of health professionals to the study protocol, medication adherence rate, and use of Riskometer app. And the surrogated endpoint, the reduction of systolic blood pressure comparing with the usual care group. So we evaluate a lot of patients, but we included in the running phase 420 patients. 13% were excluded for several causes, but only 4% excluded by adverse events. So these patients were randomized for 348. After the randomization, 10 patients stopped the medication, only 3.8% caused by adverse events. The major cause to stop the trial or the medication was the doctors telling to the patient that you don't need to use this because you don't have hypertension. So it was the main cause. So we have follow-up of 344 patients. The Polypill was very well tolerated, was created in the university where I work with a rigorous control of quality. The adverse events in the Polypill, this is for running phase. You can see here the adverse events. We have 7% of patients with dizziness, lower limb edema 5%, and myalgia and fatigue in 3%, but only 4% stopped the medication caused by adverse event. 2% serious adverse event not related with the medication. Here is the baseline characteristics, 59 years old in the Polypill group in the control, 37% woman, 50% white, tobacco use 17% and 11%, blood max index 28, 70% more than 25 with overweight, total cholesterol similar, LDL cholesterol similar, blood pressure in the baseline 130 in both groups, and you can see here the salary per month, $400 until $1,700 was the majority of patients, 6%. 78% use the Riskometer because the Riskometer was not the main cause of this pilot study. So 78% of people used the Riskometer in this phase. Here the main outcome, clinical outcome, here in the running phase, you can see it started in 130, both groups, in blue placebo, in red Polypill, and you can see here with difference, we have 6 millimeters difference from start to the trial until 6 months, and 13 millimeters with the Polypill. At the end, in 6 months, we have 7 millimeters difference between both groups. The same in diastolic, showing that really the treatment can decrease the blood pressure in the first month and keep the blood pressure lower. About the Riskometer, 82% answer that is easy to use, 82% that help to know their own risk factors, and 71% that help them to modify the risk factors. So I think there are very good results. It was a huge challenge to recruit these patients. So only in the primary care units, the patients are sick. They have hypertension, diabetes, dyslipidemia. So we start to call in the journals, in the social media, in newsletters, in training, education for the patients to bring them to evaluation, to screening for the study with this amazing team that work with me. You can see here the team in 2 hospitals that we screen these patients in the primary care units too. So you can see here in 2022, we have 500 patients screened. In these 5 months this year, we have 800 because of this initiative. In the recruitment, 100 patients recruited last year, and 250 patients recruited in 3 months this year. So it's feasible to implement with these strategies. Thanks to this amazing group that work with me and make possible to implement this challenge study. And our executive group, thanks to Valerie, to Michael Brennan, to Craig Anderson, Ralph Sacco, Graham Hankin, and the Luciano Esposato, and the cardiologists that participate together, Gisele Sampaio Silva, Otávio Pontes Neto, a lot of people participate in this study. So we saw that it's feasible to implement a clinical trial for primary prevention in this population in a middle-income country. The polypill was well tolerated. Only 4% of patients were not randomized because of adverse events. The systolic blood pressure decreased in the first month and keep the same measurements in 6 months. The Riskometer was very well accepted in the perception of the patients, and the recruitment was a challenge, but we'll learn what to do for the next trial, a challenge 80,000 patients in the whole country, 80 primary care units linked to 20 universities. Thank you.
Thank you very much, Sheila. The paper is open for questions or comments. If anybody in the hall has any questions, please come up to the mic. Also like to invite anybody who's joining us virtually that you can put your questions and it'll come out on this iPad and we can ask them for you. Maybe I'll ask the first question then, Sheila. Well, firstly, congratulations. I mean, I think that to be able to have a trial for primary prevention with a very practical, easy to implement single pill with something that we have on our smartphones with the Riskometer is something that if the subsequent study proves effective is going to be able to make a major impact for primary prevention. I guess in some ways you showed the data for hypertension. Were you able to show any other effects of this intervention in terms of lipid status and whether or not with the Riskometer in terms of activity level, obesity measures and such?
Yeah, wonderful question. The lipids were the same because 6 months didn't change. The body mass index didn't change, but the exercise increased in the group of intervention.